Beautiful. I think we'll get started for the session this afternoon. So, good afternoon, everyone, and thank you for joining us today on our webinar on accessing CAR-T therapy from a regional, rural, and remote perspective. I'm Kim, one of the lymphoma care nurses, and I will be your host today for the session. And we also have Liz here with us, one of our other lymphoma care nurses, and she'll be facilitating our Q&A session after the presentations. I would like to thank Dr. Allison Barraclough and Dr. Safia Belbachir, who will be kindly presenting today, and also a thank you to Gilead Pharmaceuticals for sponsoring this webinar. Before we dive in, I just have a few quick housekeeping items to mention. So we encourage your participation in today's session. So if you do have any questions, please feel free to pop them into the Q&A function at the bottom of the screen, as the chat function will not be monitored, and we'll have our Q&A at the end of the presentations. If you do miss anything or would like to re-watch the presentation, it is being recorded and will be uploaded to our website, and this link will be emailed to you once the recording is available. If you have any technical issues during the webinar, please email nurse@lymphoma.org.au and we'll try to address this for you. So firstly, let's introduce our presenters for this afternoon. So we have Dr. Allison Barraclough and Dr. Safia Belbachir. Allison is the Lymphoma Lead and CAR-T Program Director at Fiona Stanley Hospital in Perth. She has a special interest in immunological treatments for lymphoma and in supporting patients in rural and remote areas living with haematological malignancies. Safia is a Haematology Fellow specialising in bone marrow transplants and Car-Tcell therapy, and she is currently working as a Clinical Trials Fellow at Fiona Stanley Hospital in Perth. So we'll now get started, and I will hand over to Allison.
Thank you so much, Kim. I'm just going to share my slides. Hopefully they project well. Okay, hopefully you can see that. I really want to thank Lymphoma Australia so much, and thank you to everyone who's dialed in today. I get to talk about two things I am very passionate about. The first being remote and rural cancer care, and the second being chimeric antigen receptor T-cell therapy, or CAR-T therapy, which is this amazing bespoke immunotherapy which has really revolutionised the treatment of patients with haematological cancer in the last 5 years or so. So I live in a huge behemoth state. It spans thousands of kilometres north to south and east to west. And despite that, the population has only just ticked over 3 million now. A third of people that live in Western Australia live in remote and rural communities. That's a significant proportion. Despite this, there are disparities for patients who are living in rural and remote regions. The life expectancy, the overall mortality and mental health is worse in patients living specifically in remote locations. And this is due to a number of different compounding factors: living conditions, social isolation. I've just finished a clinic, telehealth clinic, before dialing into this meeting today. Two of my patients on the call both lived about 2 hours from the local hospital with no family support, no social support. In fact, the only time they would see someone was the lady at the local shop once a week. So, there's significant concerns with patients that are isolated, and there is a major reluctance to engage with health services in that situation. There's also significant distance from health services. So even though I do manage patients in rural and remote regions, often patients still have to travel 1 to 2 hours to get to those sites, sometimes even more. And patients that live rurally do have socioeconomic disadvantage compared to patients living in metropolitan sites. And that's for a number of reasons: the lower employment rate, a lower educational rate, and a disparity in economic resources. So the factors are complicated. So in Australia, approximately 1/3 of those affected by cancer live in regional and rural areas. That is a huge proportion of our cancer patients that do not live in metropolitan cities. Now, I hope this picture projects well to those of you that are dialed in. This is our Western Australia Cancer Health Services map. The red dots denote a regional hospital, and the dark blue notes denote a district hospital. So you can see we have quite a significant proportion of Western Australia has these services available, but there are huge amounts of space between these services. So we can do so much better. What do we know about cancer in rural Australia? What's the data? What are the statistics? Well, we know for sure that patients living with cancer in these areas have a poorer survival than those living in the major cities. Rural patients with cancer are 35% more likely to die within 5 years of diagnosis than patients in cities. And I find that astounding. That's a huge disparity. I think the factors for that are really complicated. There's less availability in some of the rural sites of diagnostic and treatment services. And I've had a number of patients say to me that if they have to leave their regional or remote home to attend a tertiary centre in a metropolitan city, they would rather die than do that. They have never left their site for their entire life. And because of this reluctance to engage with health services that we've talked about, patients are presenting later. And unfortunately, with cancer, if you're presenting with a more advanced stage disease, your outcomes are more poor. Those that travel to major centres for at least some of their care can experience significant financial and personal burdens for themselves and also their families. I've had farmers say to me that they definitely cannot travel during harvest, and that can delay diagnosis and it can delay treatment for those patients. 38% of rural hospitals administering chemotherapy have no haematologist or oncologist that go and visit on site. Some of those hospitals do have a telehealth service, however. And we also know that chemotherapy orders written by oncologists and haematologists occur in only just over half of cases. So that means that there are a significant proportion of cancer therapies that are written up outside of those specialties. As the remoteness of hospitals increases, chemotherapy is increasingly administered by staff other than chemotherapy trained nurses. Now, our chemotherapy trained nurses are essential in providing very specific care to our cancer patients. Those who have dialed in who have been on a cancer journey know that their level of knowledge and expertise is essential in creating good outcomes for our patients with cancer treatment. In Fiona Stanley Hospital, we have a hub and spoke model with both a combination of face-to-face visits and telehealth. So a number of us at Fiona Stanley, a number of haematologists and oncologists as well, travel to specific sites around Western Australia that have their own chemotherapy unit and own nursing unit on site. So there's a number of benefits to that. I think the most important thing is patients can access their chemotherapy treatment close to home, which is vitally important for mental health and also for family health as well. Some sites, patients can access diagnostic tests and staging procedures, but others they can't. And in that case, we can rapidly transfer patients to Perth to get these additional staging procedures done and assist with accommodation and transport. All the patients that are seen in these rural sites get their cases discussed at expert multidisciplinary meeting at Fiona Stanley Hospital. I chair the lymphoma meeting every Monday morning. So all my lymphoma patients get discussed in the meeting, and there's expert radiation oncologists, radiation interventionalists, anatomical pathologists, and haematologists all on that meeting. So regardless of where patients live, they get the best possible care provided. There's also the benefit if patients present to the rural hospitals unwell, that there's 24-hour registrar haematology expert support that's available, and those local hospitals can call to get the best expert advice for our patients. And if they're critically unwell, then they can come to the home hospital as well for further ongoing care. We're really proud of this model and it's working well, and we're hoping to expand into more centres in the near future. This is a map of some of the centres that we travel to. I do a face-to-face clinic in Kalgoorlie, which is over 500 kilometres away. It's a flight. And I also do a telehealth clinic to Esperance. If you have not been to Esperance, I highly recommend it. It's such a beautiful place. So this is Kalgoorlie. It's a charming, quirky place. Shout out to anyone that's dialed in from Kalgoorlie today. It's a gold mining town. This is the Super Pit, which is one of the largest gold mines in the world, which is pretty amazing to see from the air when I'm traveling over. And it has a number of these amazing, gorgeous, old-fashioned pubs scattered throughout. I don't know if this is true, but I got told that the pub to population percentage is the highest in Kalgoorlie than it is in the world. I'm not sure if that's true, but there are like 20 to 30 pubs in this tiny town. Because it's a mining town, there's a really transient population, so that brings its own challenges with it. But I love attending my clinic in Kalgoorlie. What does a typical day look like for me? Well, I'm up early. I get on the plane at about 6 o'clock in the morning. It's just over an hour flight. When I touch down in Kalgoorlie, it's always on a day where it's shift change for the miners. So when I reach Kalgoorlie at about 7 in the morning, in the airport's generally like a big tin shed. There's a big pub in the middle, and everyone's having their 7 a.m. morning beer because it's shift changeover and they're about to go home. So it's a very different way of living. Catch a taxi and I head down to the outpatient department of Kalgoorlie Hospital. There's a picture there. I probably see about 25 patients in a day of various haematological malignancies and non-malignant conditions. A number of those patients have lymphoma. We've got a dedicated cancer care unit in Kalgoorlie with excellent nurses and excellent administration staff to really help and look after our patients. And we're really proud of the service that we provide our patients. But rural and regional services aren't without their limitations. So not all treatment can be given locally. If I think about Burkitt lymphoma, for example, which is in a really aggressive B-cell non-Hodgkin lymphoma, that requires specialised CAD pump therapies or inpatient hospital stay. For those types of treatments, patients have to travel to Perth or a metro centre to receive that. Not all procedures can be done in rural locations, diagnostic procedures. Biopsies can be done on site at Kalgoorlie Hospital, but bone marrow biopsies can't, neither can PET scans or PET-CT scans for staging. So all my lymphoma patients have to travel to Perth if they're agreeable to have formal staging with a PET-CT scan. And I've sort of mentioned that there is this transient kind of lifestyle in Kalgoorlie. People move around a lot, and that makes staff turnover really high. And that can be really complicated for continuity of patient care. Also, I'm terrible at IT. So when there are IT issues, I often give up. But no, there's lots of help around. But, you know, when we're dealing with IT and patient care, it can be challenging at times. We all know that. So that can be one of the limitations as well. So now I'm just going to move on to the next bit of my talk, which is CAR-T therapy. We have given a number of patients living in rural and regional areas in Western Australia CAR-T therapy, and we have cured their lymphomas. It's a complicated process, but there's lots of support in place. So this is, I think, a treatment that's really well suited to patients that live in the country, because ultimately it's a one-off infusion. And then when things are okay from a side effect perspective, you get to go home, hopefully cured of your disease. So what do normal T cells do? Well, T cells find abnormal cells in the body and kill them. This is a picture of a biopsy of a patient who had diffuse large B-cell lymphoma. You can see the really large cells in here, they're the cancer cells, but anyone that's got good eyes can maybe see in between those cancer cells much smaller cells, and some of those represent T cells. Now, those T cells should actually be acknowledging that they're surrounded by foreign cells and they should be acting to destroy and kill those cells, but they're not. And they're not because the cancer cells are incredibly clever at producing hormones and chemicals and receptors to basically shut down those T cells to make them inactive. So they're not doing the job they should do. So that's where CAR-T therapy comes in. So CAR-T therapy uses a patient's own T cells, and we genetically modify those T cells to express a receptor on the surface that specifically targets the cancer cell, and then additional machinery within the T cell. So when the T cell with the receptor binds to the cancer cell, it kills the cancer cell. So it's this amazing therapy where we're manipulating the patient's own immune system to kill their cancer. There's been many iterations of these CAR-T therapies, first generation, second generation, third generation. There's more now. Most of the data focuses on the second generation CAR-T therapy, and that's the type of construct we give at Fiona Stanley Hospital. It's a fully reimbursed treatment. Who can we give CAR-T through? Well, there's excellent data, and we can give CAR-T to 3 types of lymphoma in the relapsed refractory setting. Most commonly, diffuse large B-cell lymphoma, which is the most common aggressive non-Hodgkin lymphoma, and more rarely, relapsed refractory mantle cell lymphoma and relapsed refractory B acute lymphoblastic leukemia. Now, CAR-T therapy is a curative intent therapy for diffuse large B-cell lymphoma. And I really don't have time to talk about all the data. I could probably talk about it all day, but I just wanted to highlight one study, the ZUMA-7 study. And it was the first time in decades where we've seen an overall survival advantage with a new treatment. So this was CAR-T therapy over standard of care therapy, which was traditional chemotherapy and an autologous stem cell transplant. And this really revolutionised the way we think about treating our lymphomas now, and it's allowed access to patients with diffuse large B-cell lymphoma in the second line now. I was there when this data was first presented at the American Society of Haematology conference, and there was standing room only. It was such an amazing outcome for our group of patients with diffuse large B-cell lymphoma. The manufacturing process is complicated. So patients are attached to an apheresis machine, kind of like a dialysis machine, if you picture that. Blood comes out, we take off the T cells that we need, and we put the rest of the blood back in the body. The cells are then sent all the way over to El Segundo in Los Angeles in the US, and it's there that the genetic manipulation occurs. It takes about 3 weeks to get the cells back to us, and it's my job during that time to keep patients' lymphoma stable before we reinfuse the cells. So if there's a very low burden of disease, sometimes we just watch and do nothing. Other times we employ things like high-dose steroid, gentle chemotherapy, or radiotherapy to really try and keep the disease at bay. Then once the cells have come back, we give something called lymphodepleting chemotherapy, and that's not to kill the cancer cells, that's actually to prepare the body to make the optimal environment for the best possible expansion of these brand new CAR-T cells. So we kill suppressive cells that would hinder that expansion. Then patients are admitted to hospital for 7 days, where we look for all the unique toxicities associated with CAR-T therapy. And if all is well, patients are discharged and have to stay in the vicinity of Fiona Stanley Hospital for the next 3 weeks following the infusion. And if all is well at that time point, that's when we do the first PET scan and patients are well, then they can go home back to their rural and remote location, and they can be followed up by their local haematologist with us in the background doing regular scans and imaging and looking after any special side effects associated with the CAR-T. This journey of CAR-T is complicated. It's logistically complicated as well. But as I said, we've successfully got a number of patients who live remotely or regionally through this complicated process. We've talked about bridging therapy after the T cells are collected, and then we really try and get patients home for a week, just to get home, to spend time with their family before the trip back to Perth. where we organise a number of scans leading up to the infusion date. We restage with a PET scan. We make sure the lymphoma hasn't invaded the brain or the spinal cord. We check heart function. We check other organ function to make sure patients are fit enough to get the therapy, and then they're infused in. And just to get a bit of an idea of the complexity of all of this, this is an example of a schedule that we would provide to our patients to tell them where they have to be, what they have to be doing, and when they have to do it. And that's all the things that they have to do leading up to infusion. So despite all of this, despite the complexities, we think it's really worthwhile to get patients this therapy because it's life-saving therapy. So how do we support our rural and remote CAR-T patients to get them through this process? We rely on our absolutely brilliant nurse coordinators from all the different sites around Western Australia, working with our nurses at Fiona Stanley Hospital. And we case manage patients' unique circumstances. We understand that sometimes you have to travel with your pets or children or, anything, and we can accommodate that. So we can get accommodation for patients to accommodate all of those things. And, we really do everything we can to get a patient through this process. We use a lot of telehealth. We use a lot of telephone appointments to try and minimise the time that you have to spend in Perth, because we know you don't want to be here. So we really try hard to do that. And we arrange all the travel and accommodation for patients and families during that time, which is all free of charge. And then importantly, we discharge you back to your treating haematologist, which is equally important because we know that you want to go home. So to conclude, hopefully I've shown you that I really believe that all patients should have access to life-saving treatments, including CAR-T therapies, no matter where they live in Australia. It's really crucial to have a multidisciplinary approach to support patients living rurally and remotely, because they have really unique circumstances, very different to our metropolitan patients. And also, finally, we always want to make things better. So if anyone has any ideas on how to improve our services rurally or remotely, or anything in regards to CAR-T therapy, we really want to hear from you. So that's all I have to say today. And I'm going to stop sharing and hand over to my excellent colleague, Dr. Safia Belbachir, who is going to illustrate all of this with a case study now. Over to you, Safia.
Hello, my name is Safia, and I will be doing a case discussion. A pretty atypical one, but just to illustrate the type of patients that we see here at Fiona Stanley. I just wanted to show where our CAR-T-cell patients come from in WA. Those red dots are unique patients that received CAR-T-cell therapy at Fiona Stanley Hospital. And as you can see, they come from all of WA, not just metropolitan regions. And the distances they travel is very dramatically. We have some patients that come from the next suburb, and they were at 0.17 kilometers from our center, and some people that traveled 1,629 kilometers to Fiona Stanley. And I just wanted to show that the patients that we've infused, 73.6% of them live in metropolitan WA, and 26.4% are actually rural and regional. This correlates really well with the general population in WA. I looked up the Australian Bureau of Statistics population distribution in WA, and it's pretty similar. 79% of WA's population is metropolitan, and 21% is remote and regional. And it also correlates to the numbers that Allison mentioned above in her presentation of the third of the cancer patient that we see that come from regional and rural centers. So what I thought would be interesting to look at is to actually compare the patient journey of a patient of regional patients and a metropolitan patients that were both infused in our center. And I've randomly chosen 2 patients. One of them lives at 1,340 kilometers away, and one of them 18 kilometers away. So our patient, Mr. M, is a 59-year-old patient, lives in Port Hedland. He's an accounts manager. He lives with his wife and 2 adult children in Port Hedland. The metropolitan patient is Mr. V, a 37-year-old patient that lives in Metro Perth, and he's a lawyer, lives with his partner. They had a pretty similar lymphoma journey overall. Those are their PET scans at diagnosis, and both of them were diagnosed late 2023, early 2024. Both of them received the same first-line treatment that we give for diffuse large B-cell lymphoma, which is R-CHOP. Mr. V, our metropolitan patient, did not respond to his first-line treatment. Mr. M had a brief 2-month response, but failed his first-line treatment. Both of them had salvage chemotherapy as a second line, and both of them failed their second-line treatment, and they were referred to us for Car-Tcell treatment. At that time, Car-Tcells were indicated for third-line treatment for the LBCL. Now we have them earlier in second line based on the ZUMA-7 trial that Allison just spoke about. So both of them were very sick patients with very aggressive disease. So if we compare the timeline of their treatment, the rural patients, Mr. M, relapsed in January 21st. 8 days after confirming relapse by his PET scan, he was referred to us. For Mr. M, his referring physician emailed our unit, and we've arranged to review Mr. M the next day after doing an on-paper screening for eligibility. He was deemed eligible on paper, and we've arranged for him to travel the next day to Perth, thanks to our brilliant nurse coordinator. He was reviewed the next day, and when we review a patient, if he's deemed eligible, we do the screening bloods all the same day to make sure that we're not wasting any time. And we've arranged for his apheresis, or the cell collection, that the cells that we send for manufacturing, to happen 4 days later. So this his infusion also happened 30 days later, which is the classic timeline. Mr. V, however, was actually referred when his referring patient had the results of his PET scan, which was a day after the PET scan. Since his metropolitan, we've reviewed him the next day also, and a apheresis was arranged 6 days later. His infusion also happened 31 days after. So if you compare the time from relapse to infusion, 43 days for the rural patient and 39 days for the metropolitan patient, which is actually a great achievement because the 43 days is actually the classic metropolitan timeline in other centers. So although there is a delay of 4 days, and if we look into what caused that delay, it was mainly the time from relapse to specialist referral, which is a challenge in rural regions, because Mr. M had to come to Perth to have his PET scan, go back to Port Hedland, and then his doctor had to wait for the results of the PET scan and then refer him back. But the metropolitan patient had the results of his PET scan the same day, with the review of his hematologist the next day. So the metropolitan patient's time from relapse to referral was just 1 day versus 8 days for the rural patients. And if we compare the key treatment phases that Allison was talking about in her presentation, So from relapse referral, as I said, 8 days versus 1 day. But once we get the patient into the CAR-T clinic, everything moves the same. So referral to review, similar 1 day. Review to apheresis, pretty similar. And apheresis to infusion, also pretty similar. So overall, the journey is 43 days versus 39 days, which is also, again, even for the rural patient, 43 days is actually an excellent timelines. If we look historically, it was in months before. What I want to illustrate is the vein-to-vein time versus brain-to-vein time. So the vein-to-vein time is the time from collection, where we collect the cells, and then the time we infuse the cells. So this happens once our CAR-T clinic is aware of the patients, and as you can see, it's pretty similar between both our patients. The brain-to-vein time, though, is from relapse or CAR-T-cell indication by the referring doctor to the infusion, and I think this is where the delays are happening generally for our rural patients. I just wanted to illustrate that having the vein-to-vein time be this low and pretty similar is quite an achievement for WA, since the patient cells actually traveled 30,000 kilometers from the manufacture sites, from the collection site, Fiona Stanley, to the US, gets manufactured and come back to Fiona Stanley. So very long journey. It's actually the farthest infusion sites in the world for one of the products, Yescarta, that those patients received. So the challenges, I think Allison went through them in details, but for our patients, especially our Mr. M, the delay was in the CAR-T-cell indication or the referral process. So how did we overcome those challenges with our rural patients? So the Allison was leading an excellent early access referral program here at Fiona Stanley Hospital, and we've slashed the vein-to-vein time and even brain-to-vein time quite significantly and quite successfully due to that. As she mentioned, we do have an effective regional referral pathway, our hub-to-spoke model, and most of our consultants actually travel to those regional sites and can facilitate those referrals. We have a great relationship with our referring centers and physicians, and they know they can just email us and we can take on those patients. We have a pretty strong MDT team, multidisciplinary care team. As Allison mentioned, she shares the lymphoma MDT, which discusses those patients quite in detail with the presence of multiple disciplines. The patients are screened promptly on referral, so the patients are usually either phone calls or emails pre the formal referral by our system. We have an e-referral system, but usually we hear about the patient way before we get the e-referral. We assess them on paper to make sure that it's worth their travel. And if they're eligible, we book them in the next open clinic. And sometimes it's the same day, the next day as the referral. We can contact the patients promptly. Our CAR-T nurse coordinator is very effective at that, and she explains the logistics, confirms appointments. Allison showed you our schedule, which is pretty complicated, but she does a great job of making it simple and easy to understand to our patients. The other area of improvement was streamlining cell collection logistics. So we have an excellent lab team. They have a very flexible apheresis schedule, and we can collect our patients with ease, with minimal delays, which is, I think, it's a huge advantage we have here in WA. And again, as I said, we give very thorough education for the patient and their caregivers, and very simple, easy to follow plans to make things clear and easy to follow. We also optimize administration and support. Once you are deemed eligible, your cells are collected. You have to have, as Alison was mentioning, bridging chemotherapy to wait for those cells to come back. You have to have lymphodepletion chemotherapy. You have to have imaging done, PET scans, sometimes MRIs, physio reviews. So for the patients who don't have local support, we can arrange local accommodation. And for that rural patient that I was talking about, he had a accommodation arranged by Rare Cancers Australia, and we are very thankful to them. We also have the PAT program for travel support. We also don't keep the patients long after. We make sure that treatment is side effects are completely gone. So we usually discharge them early and let them go home, and we coordinate with the referring doctors to make sure the care continues in a appropriate manner. So my conclusion is every patient who is eligible for CAR-T-cell therapy deserves timely and equitable access, regardless of geography, socioeconomic status, or logistical challenges. I think we're very lucky here in Australia that we have a good support system, and if you are eligible for CAR-Ts, you should be able to get CAR-Ts quite promptly. With early coordination, flexible logistics, and collaboration, we can overcome those barriers. There are still barriers that needs to be dealt with, but improvement is happening all the time. We streamline the patient journey, but tailor it to their individual needs, from the referral to post-infusion care. And we make sure that access is mainly guided by the clinical need, not the circumstances of the patients, be it financial or geographical or socioeconomic. This is our CAR-T-cell team made of the doctors, our coordinator nurse, the pharmacist, the clinical trial team, the physios are here, and the lab team is also here. This concludes my presentation, and I'm happy to answer any questions. Thank you.
Thank you very much to Alison and Safia for your fantastic overview of accessing CAR-T from a regional, rural, and remote perspective. I think we can all agree today that the session has been so valuable in further understanding how we can access CAR-T in these areas, as well as what's involved. I'm now going to hand over to Liz, who's been monitoring some incoming questions we've received, and Alison and Safia will answer them. Thank you.
Sorry, there we go. So I'm just going to open up some questions that Alison has already answered, just in case anyone's not monitoring the chat. So Eliza just wanted to clarify, are GPs ordering chemotherapy in areas with no haematologist? How does this impact care? So Alison has written, it's more likely to be specialised general physician working on site. They would do it in consultation with the haematologist oncologist. Her major concern would be that dose reductions or modifications may not happen correctly if specifically charted by a haematologist. David has also written, how tough on the body are the pre-treatments of chemo? So Alison has written, the lymphodepleting chemotherapy given just prior to CAR-T therapy is generally well tolerated. A week of fatigue and mild reductions in blood counts are the most common side effects. And Thompson has written, how many countries are sending their patients' specimens to Los Angeles to get them manufactured? Are there many centres throughout the world doing this? So Alison has written again, the site of manufacture depends on which CAR-T products you are using. We use 2 products in Australia. Yescarta is the most commonly used product, and that is manufactured in LA, and countries all over the world send cells to them for manufacturing. There are other sites in the world that also manufacture too. And so we've got a few open ones. So Safia and Alison, what is involved in the collection of cells?
Do you want me to take this one, Safia? You can do the next one.
Sure.
So we sort of talked a little bit about this. So you come in for the day to our outpatient unit, and you're hooked up to a machine called an apheresis machine. If you've got excellent veins, then you get a cannula in each arm. If you don't have very good veins, you get a bigger line put in for the procedure of collecting the cells. Your blood comes out, the blood's spun down, and we take off the bit we need. So we need the T cells, they come off. The rest of the blood goes back into the body. It's generally really well tolerated. Patients are really tired by the end of the day just from having the procedure done. The major risks really are blood pressure fluctuations, issues with the blood going in and out of the body, the lines clotting, those sorts of things. But generally the procedure goes really well. We get enough cells within the course of a day. It's extremely rare that we have to put a patient back on the machine to recollect cells. So it's a pretty straightforward procedure. We do it for a number of other things, like we collect stem cells in a very similar way when we're doing a stem cell transplant as well. So we use these machines for various things, but that's basically how we do it.
Thank you. What is the success rate? What is current mortality rate? Long-term side effects? That's from Margaret in Southern New South Wales. And she's also written, is there a similar service offering CAR-T here or in Victoria?
Okay, do you want me to answer, Alison?
Yeah, go for it.
So it depends on what you're getting CAR-Ts for and what product you get your CAR-Ts for, what line of treatment you're getting your CAR-Ts for. But just to illustrate, those patients had their CAR-Ts for DLBCL in 3rd line. They had Yescarta, the product that's manufactured in LA, and we managed to cure around like 40% of those people. The main toxicities are acute ones. This is why we like to keep the patient close to the infusion center for the first month. The patient will be admitted for at least the first week after CAR-Tcell infusion for mainly inflammatory responses, inflammatory type toxicities. We call that CRS, or cytokine release syndrome, and it's like a bad cold with fever. We know very well how to treat that. We have specific treatment for that. The other toxicity is neurotoxicity. We call that ICANS. It happens in fewer patients, and the treatment is steroids, basically. It's completely reversible, 100% reversible. The other toxicities, as Alison was saying, would probably relate to the chemo you've had right before the CAR-Ts, which is a mild drop in your blood count, so that would recover. We can have mild drop in blood counts go on slightly longer, but those are very well tolerated, and we know how to mitigate those. The other side effects that happened with other chemotherapy, other types of treatment, is infections. And in hematology, we deal with infections all the time, and we know how to manage infections. What was the other question? Sorry, toxicities. And
living in Southern New South Wales, what other similar services are available in, I guess, in Victoria, Australia?
So New South Wales and Victoria, both of them have excellent CAR-Tcell infusion center, and multiple of them, I think, in Victoria. New South Wales, there's just one, Alison, or multiple?
There's There's actually two in New South Wales, and there's another 2 sites that are going to be opening up soon. So, Margaret, you are going to have many CAR-T centres in New South Wales, and there's 2 in Victoria.
Yeah.
We all do the same thing. So at the moment, there's 8 centres around Australia. We all offer the same products. We all infuse for the same indications. So it's really standardised around Australia. We meet every Tuesday morning nationally. So all the CAR-T leads and the CAR-T centres lead, we discuss all the patients that we're going to infuse at our site. So it's a really collaborative approach. So it doesn't matter which site you go to in Australia, you'll get the same excellent care. Yeah, and then I think the other question Margaret had was about mortality. Well, actually, the risk of death with the actual CAR-T construct is very low. So the risk of death from the side effects is very low. But unfortunately, the majority of patients, you know, we cure 40 to 50% of patients with diffuse large B-cell lymphoma, and unfortunately, the rate of death is mostly associated with disease progression more than the toxicity itself. But there are definite toxicities associated that Safia talked about, and they can lead to death, unfortunately, in a small proportion of patients, despite all our best efforts.
Thank you. So David's written, what other lymphomas are likely to be able to access CAR-T therapy in the near future or as 2nd or 3rd line treatment?
Well, the excellent news is we have now CAR-T cells for 2nd line DLBCL, which, as Allison showed in that curve, had the first overall survival advantage in almost like 30 years in DLBCL. The other lymphomas we have CAR-T cells for is mantle cell lymphoma. We have Tecartus in 3rd line. The other one is follicular lymphoma that the company is trying to get approval for in 3rd line too. We have clinical trials of CAR-T cells even in front line early primary refractory aggressive DLBCL, but it's not standard of care yet. So it's mostly earlier lines are mostly for clinical trials. Other than follicular lymphoma, no other approval is sought for now. Allison?
So other than what Safia said, it's mainly there's so many clinical trials going on for all types of lymphomas. So we've got a clinical trial for follicular lymphoma, marginal zone lymphoma as well. There's work looking at CAR-T for Hodgkin lymphoma. So really, there's so much work going on around the world looking at different approaches for not just lymphomas, but all types of cancers actually. But yes, the current indications that we have are unlikely to change in the near future. But yes, there's other cancers like multiple myeloma as well. So we've got access to CAR-T coming for multiple myeloma patients towards the end of the year.
Thank you. So Eliza has written, do you encounter any logistical issues with the transport to the USA?
Personally, we haven't at our site. It's such a regulated way of getting the cells. They go in these very special little boxes, little eskies, which are temperature regulated. There's thermometers in there. The temperature is tracked through transit. So they're watched all the way through the whole process of transit there. They're actually frozen there, and they send back to us frozen for the vast majority of cellular products. So we haven't had any issues, but where the issues can arise, not with the transport, but it's with the actual production of the CAR-T cells themselves. So in a small proportion of patients, the CAR-Ts just won't grow. So that can be a really devastating outcome for some patients because we've gone through the whole process, and sometimes it's not before infusion that we actually find out that the CAR-Ts haven't worked. And sometimes by that late time, the patients don't have time to wait for another recollection and remanufacture. So sometimes we have to think of a backup plan at that stage, but that is very, very uncommon.
And just following on from that question, how close are we to producing our own CAR-T cells in Australia rather than sending to the US?
Yeah, so there are some sites in Australia. I think Brisbane has been the most successful of manufacturing CAR-T locally. So they run a clinical trial for patients that can't access the standard of care CAR that we're talking about. They enroll them in this clinical trial and it gives them access to CAR-T. There are a number of sites around Australia that are in the process of trying to manufacture now. It's quite a complicated process, but definitely not impossible. But in Australia, it's so highly regulated that will need to be run on small numbers of patients through clinical trials. There are countries around the world, however, where they don't have access to standard of care CAR-T, where they manufacture all CAR-T themselves. So New Zealand is one of those sites where they manufacture all their own CAR-T because their government couldn't afford commercial CAR-T because it's such a big outlay. And India as well is another big site, and Spain is another big site for on-site manufacture. So, you know, lots is changing in this sphere.
So Loretta's asked, regarding early discharge for rural patients, how soon after infusion would be an early discharge compared to local metropolitan patients? Is there a discharge to local accommodation first?
Yeah, so I can answer that.
So
all of our patients actually are discharged back to the referring site at day 30. So the way we manage that is the patient will get their disease assessment at day 30. It's very fast, knowing whether the CAR-Ts worked or not. Just 4 weeks in, you get your PET scan, and we know, did it work? It didn't work, but either way, you get discharged back to your referring center at day 30, so a month after infusion. If all goes well and there are no lingering side effects and all that, the patients will be reviewed in the CAR-T clinic at month 3, month 6, and month 12 with PET scans just to make sure that disease is still in remission if they manage to achieve remission. And as I said, both rural and metropolitan will have the same happen. The difference maybe is for our patients when they're discharged from the unit at let's say day 10 after infusion, when all the side effects have resolved and they can be at home. Our metropolitan patients would go back home, and the rural patients will have hopefully accommodation with a carer. And the patients will have, all patients will have visits by nurses from our ACTS team, our home program, 3 daily up until day 14, and every 2 days up until day 28. So that would be the difference between the two, but mainly pretty similar process once they get infused.
Thanks. Do you have any options or procedures for a potential relapse that has occurred following CAR-T therapy?
Yes, there are usually we always have options. So it really depends on what we're treating. So if we're talking about the most common indication, which is diffuse large B-cell lymphoma, we've recently got access to another type of immunotherapy, bispecific therapy, in the 3rd line. So it's a drug called epcoritamab. So that's a really good drug to access post CAR-T failure. And we're seeing really good outcomes with that approach as well. And then, of course, there's clinical trials. There's always new agents that are on the horizon. So, you know, I think it's really important if you're in that situation to reach out to Lymphoma Australia, do your own research, look to see if there's any clinical trial options close to home, or even if they're not close to home, you know, there are many people that can support you to get to that clinical trial.
And this next question is about funding, like funding support. So the funding to support rural patients to attend medical care in metropolitan area is that covered by state government, health, or other sources?
We actually get the pharmaceutical company to cover the accommodation through Rare Cancer Australia. So that's the company. It depends a little bit on what we're doing and what we're giving. But if we can, in any situations, if we can get the pharmaceutical companies to pay for things, we always try to do that because it saves the government money. But then we rely on anything we can rely on. We've got a system called PATS in Western Australia. I don't know if that's similar to other parts of Western Australia, which is also funded by the government. But for CAR-T therapy in particular, we do have support from the pharmaceutical companies to offer funding for accommodation and transport.
Great. Liz has asked, are there any plans to introduce haematology services in other regions like Kimberley or Pilbara?
Pilbara. Liz. There's always plans. It's just, you know, having the time, having the staff to go out there, having the people dedicated to building those services up. That's always the hurdle and the obstacle. But of course, you know, we definitely want to expand further. And I know WAX is looking into further expansion as well.
This is another specific one. I'm not sure who has that. So could you please show the schedule again? Is that given to the patient up front or used as a checklist for staff to coordinate appointments?
I think that was in Allison's presentation.
Is that me? Okay.
So maybe I'll give Allison just a minute to find it and I'll move on to the next question.
Okay.
Someone has just noted Queensland has strong support from the Leukemia Foundation in Brisbane or the Cancer Council in regional as well. That's a good tip from Ron. Madhusudan is right. Can you please write the drug name again? Is that
which drug? Which
Oh,
drug
so
do you want?
I assume the car. Maybe he was talking about the bispecific that you were saying.
Oh, epcoritamab. Yep, Kathy can put that in the chat. Can you see the schedule now? I'm not sure. Am I sharing it?
We can. Yes. Yep.
Yeah. So this schedule is given to all our patients as they go through the CAR-T process. So you'll come in and you'll meet us on the day that you meet us. Generally, we'll sign consent to collect your T cells. And after that appointment, our coordinators will start working and booking this schedule. So it's given to the patient, it's given to the doctor that's referred you to us so they can monitor your process through the whole CAR-T journey. Sometimes this changes a little bit on the way, but generally this is kind of your gospel, and patients are given this relatively early on in the journey.
Thank you. And we've just got one last question. Are there any environmental issues in the production or administration of CAR-T? Does this treatment have any issues that are harmful or leave pollution in the environment? So I'm not sure if this is...
Yeah, I can answer that. So there is, if you discount the flights, the carbon prints of the flights to the LA and coming back, it has very small footprints on the environment. So the cells are collected here. We use like electricity here, which is, I think in WA, we have lots of renewables sources of energy, and other than the actual product, which is a patient cells and some plasma, it has zero impact. It is packaged in plastics though, so I don't know how much, but one bag, I think in the grand scheme of things, it's not major. The product is sent. The manufacturing itself also is a very low footprint. It's the machine can sit on a tabletop. It's not massive. It doesn't require any I don't know, like AI, for example, requires huge amounts of like water to function. It doesn't. And then the cells are sent back and infused with minimal again, footprints on the environment. So other than the reusables we need for the actual care, which probably won't be different than the standard of care, you still would need to use like cannulas and all that, even if you get standard of care. It doesn't have any harmful impact. It's just living cells. It's a living drug. It's definitely better than chemotherapy, which goes into our water systems and all that. Even though it's diluted, it's still there. So it's just a living cell. It's a living drug. So I feel like even for the environments, CAR-Ts are much, much better than the chemotherapy. I don't know if this answers your question.
It does. Thank you, Safia. I think that is our last question. I might just hand back over to Kim. Finish up. Hi, Kim.
Hi guys, thank you. So now that we've answered all the questions, Liz and I thought we would take a moment to introduce our new CAR-T and our regional, rural and remote information hubs that are on our webpage. So these hubs are full of useful information regarding these areas. And as you can see now, Liz is just sharing her screen to show you where these are on our website and what type of information is on there. And Liz will just do a quick run through on what's on these pages.
Back on. So as you can see here, this is our homepage. You go learn about lymphoma. There's lots of information, but we're looking specifically at treatments. And we've got a new CAR-T hub, which you can see down the left-hand side. Plenty of information. I won't focus too much, but if you go treatment navigation, you can see all the tabs. You can see the process. You can have a look at where the therapies are available in Australia, which, as we can see, we've got the adults available in the centres in Victoria, New South Wales, Queensland, Western Australia, and soon awaiting an application in South Australia. So that's just some information there. In terms of our rural, regional, remote hub, if you go under patient support, you can go straight here. It's just got a lot of relevant information that could be helpful. So it's quite extensive. I'm just going to scroll down just so you get an idea of what we can do, like your to-do list waiting. But we will send out both those links in when we send out the recording to everyone who's registered as well.
Beautiful. Thank you, Liz. So in closing, thank you everyone again for attending our webinar this afternoon. We really appreciate everyone taking the time, and we hope you've all been able to increase your knowledge on CAR-T therapy and how to navigate, the access from regional, rural and remote perspective. Thank you again to Allison and Safia for being with us today and sharing your expertise. And another thank you to Gilead for sponsoring today's session. If you do have any questions regarding your lymphoma diagnosis, treatment, or you're needing more information or support, please reach out to us either via email, nurse@lymphoma.org.au, or you're more than welcome to give us a call on our nurse support line. That number is 1800 953 081, and we can also pop this in the chat for you. We would love to see you again in our upcoming online or in-person support groups or our future webinars or events. So keep an eye on our emails and events calendar for future dates. Thank you, everyone.
Thanks. Bye.
Thank you.